Okay, so we're going to get started with the didactic section of the Trabectome training. On the agenda, we're first going to go through the technology and background on how it came to come to market, a little bit about angle anatomy, some of the features of the Trabectome system, followed by the surgical steps, a couple of videos, and some of the most recent published data supporting the safety and efficacy of the device, as well as a quick summary, and then we'll go to wet lab. The Trabectome system was FDA cleared in 2006, and a lot of the data that was used to prove the initial safety and efficacy was performed in 2003 and 2004 in the original clinical trials that were performed outside the United States. And since it came to market in 2006, it has been quickly adopted worldwide and is essentially on every continent and many countries, including Europe and Canada. It's very popular in Europe and Canada. In China, most recently, it's been used in Japan, and one of the strongest supporters of the technology has been in Japan. We have a lot of collaborators there that publish widely as well. In Korea, South Africa, the Middle East, Australia, lots of German users as well. To give you a little bit of background on angle anatomy, I know you're familiar with all of this already. We're going to use a gonio lens to place on the eye and identify the angle structures. Obviously, the trabecular meshwork is the easiest identifiable structure when it's pigmented, but when it's non-pigmented, you want to look for any iris processes, Schwalbe's line, scleral spur to help guide your identification of it. So as you know, Schlemms Canal goes all the way around 360 degrees, but there is some controversy about whether or not there are septations within the canal. I believe that there are, certainly after doing several hundred trabectome procedures and being in the canal. I can tell you that there will be some tactile feedback, and you can feel when you've come up against a septa. And it's very helpful to kind of back up a little bit with the tip of the handpiece and then proceed again. But I definitely feel that there are septations within it, and so that's why trabectome is so appealing to me, because I feel that using this device and getting a very wide arc of ablation, you're able to access many collector channels, whereas a lot of the other angle surgeries right now are very small. They're micro surgeries within the canal that don't access the collector channels that are at septa that are downstream. And so with the trabectome system, when you open as many septations as possible, you are able to access a wide area of the collector channels and therefore get a better IOP reduction, a more robust IOP reduction than what is seen in some of these microstents. This is a very nice image showing the Schlemms Canal and some of the collector channels there, and the deep scleral plexus and the episcleral vasculature through which the aqueous drains. This is a very nice image because typically after doing cataract surgery or reducing the eye pressure by any kind of incision through the cornea, you will get reflex bleeding into Schlemms Canal, and the canal lights up quite nicely. And so typically I like to do trabectome after my cataract surgeries. A lot of surgeons, when doing a combination cataract trabectome, like to do the reverse. But I find that if you take the lens out first and you deepen the angle and lower the IOP, this is the image that you get when you place the gonio lens on. And so the angle anatomy is very easily identifiable, and everything is, it's basically just lit up for you with reflex bleeding. And so this is a common picture that you'll see when you place the gonio lens on after doing a cataract extraction. So the canal is right there for you. The Trabectome Features, there is a console with a power unit there. Basically one dial for the flow and one dial for the power, so it's very easy for your operating room staff. The irrigation is through gravity, so you hang the BSS on an IV pole, and I like to just raise it as high as I can get it, and that will really give you a nice deep chamber. So there isn't a lot of complex fluidics involved. The Trabectome gonio lens comes in right and left-handed models. It's a direct gonio lens and is very nice even in very small palpebral fissure patients. It is a nice small lens that fits on the eye very nicely. Some of these newer lenses that have come to market with this wave of angle technology, I find that the base of the lens is really too wide to get into patients who have very narrow fissures, so I really like the original one that comes in this kit. The handpiece is obviously disposable and comes in the pack, as well as the knife, which is a 1.8 millimeter blade, which is quite nice, and then the tubing. The foot pedal is very simple. It has a little black button that controls continuous irrigation, just on-off. And then the foot pedal, when you depress it, activates irrigation if you haven't pressed the little black button. When you press a little further down, you end up with aspiration. You can hear that. It's a different tune. And then when you press a little bit further down, you get the electrocautery. And it's an all or nothing. So it's not like a phaco where you depress and you get variable power. You set the power on the console, and then when you depress the foot pedal, it's an all or nothing electrocautery activation. This is a blow up of the handpiece. You see basically there's a protective foot plate back there to protect the outer wall of Schlemms Canal from collateral thermal injury. There's an active and return electrode, which comprise the electrocautery element of the device, an irrigation port that's at the back end of the handpiece, and aspiration as well. And so this is very appealing because when you insert this into the chamber, you get chamber maintenance. You don't have to worry about flattening of your chamber, which you do with many of the other angle surgeries. They don't have an irrigation port connected to them, or aspiration. So if you get any reflux bleeding or pigment or anything else released, it kind of clouds your view, and it can get very complex very quickly. But with this, because there's IA, things are very clear for the duration of your procedure. And again, another graphic showing what the device looks like when it's inserted into the canal and it's performing the trabecular ablation. This is scanning electron microscopy showing an intact trabecular meshwork on the left, and then what it looks like once it's undergone ablation with the Trabectome device. It's a nice clean ablation, and you notice the back wall of Schlemms Canal is nice and intact without any injury, and all the architecture is still untouched. And then you see on the far right the ostium of the collector channels. Architecture is intact and everything looks nice and clean. So this is quite different than goniotomy, where you take a knife and you just cut and the back wall of Schlemms Canal is sliced. The ostia of the collector channels are cut through and there's flaps of tissue everywhere. This maintains all of the architecture as it should be. Again, another image of it in cross-section of trabecular meshwork on the left there, and once it's been removed, the key thing to notice here is that the meshwork is in fact ablated as opposed to just cut, where the cut ends can become, again, in apposition to one another, and fibrosis can lead to closure of the cleft, which occurs with just goniotomy with cutting or other cutting mechanisms where all you do is cut the tissue. This actually removes it, and so the ends of the meshwork there you see in the center image are not in apposition to one another, and they really cannot fibrose down and close off. Okay, we're going to go through the steps of the surgical procedure. This is similar to a phaco setup where the surgeon sits temporal to the patient. You tilt the microscope away from the surgeon about 30 degrees roughly, and you tilt the head of the patient again away from the surgeon. I typically do about 45 degrees at least, but maybe a little bit more. And then you often, if you're going straight from phaco, once you put the lens on, you have to bring the microscope down a little bit to re-establish focus. So it's a different focal plane with the gonio lens on the eye.
What size phaco incision port do you use?
2.7, and then I will put, no, you have to put a single, I use the 10-0 Vicryl through, not right through halfway through the incision, just a little off, and then it's perfect, and it really makes a nice seal. And then you ask the patient to look away from you. So if they're looking straight ahead, their head is tilted away and the microscope is tilted, you still won't get a good view. You have to ask the patient to look away from you, and then you should get a nice view. So if you're doing this alone, not in combination with cataract surgery, you start off by making a uniplanar incision, I think is best, as opposed to most of us are used to just doing a biplanar or triplanar incision for phaco. That causes a little bit of, I think, torque on the wound, so I just go straight in and out with the Trabectome blade. It's 1.8. I don't use viscoelastic, but you certainly can if you like to. I find that the handpiece IA is perfectly enough to maintain a nice chamber. And I find that viscoelastic makes these optical zones in your view that are sometimes, you know, as you notice when you're doing phaco, yeah, it can make these different optical zones when you're working through it. So I don't like to use it, but certainly if you like to, it works fine with it. You insert the handpiece once you've pressed the little black button on the foot pedal to activate continuous irrigation. And then you identify your landmarks. You insert the tip of the device into the trabecular meshwork. And you either can insert it directly across from you and do a far ablation as you can, superiorly or inferiorly, and then turn the handpiece around and go in the other direction. I think that's just a little too much movement and action. I just like to put it in as far as I can, inferiorly, insert it, and then just do one long arc as far superior as possible. I usually can get about 120 degrees at least doing that, and then I'm out of there. And then you just withdraw the handpiece, and usually you don't need to put a stitch through such a small incision. And there will be reflux bleeding, so you should expect to see blood coming into the AC afterwards. Just take a BSS on a cannula and irrigate it out, and then reestablish firm pressure. I would make sure the pressure is at least 20. I like to take it to at least 25 or so, and that tamponades the bleeding. If you like to leave the eye nice and soft like you would after a phaco, for example, at 15, it'll fill up with more blood, and post-op day 1 you'll have more blood to deal with and decreased vision. So patients are happier if you leave the eye nice and firm at the end of this case to minimize reflux bleeding. This is just an animation of the surgical steps. Again, that's straight in and out, uniplanar. It's nice to have a clear cornea with some lubrication, but it doesn't require a coupling agent. This lens doesn't require any visco or any other kind of gel underneath it.
So you're right-handed, so you go all the way down?
Exactly.
And it's not a weird angle when you try to get in? Or you just make it a little...
I usually go all the way in, and I see the tip of my handpiece under the gonio lens in the angle, and then I go as far down as I can, engage the TM, go into the canal. Usually have to back up a little bit, and then go as far as I can in one long sweep. And then I will often come back down and do it a couple more times just to make sure I've got any little strands that are there. And I really like to push down on the iris a little bit and look at that white stripe, which is the back wall of Schlemms Canal. It's just kind of fun when you see it, and there's no reason to do it, I just like to. And then you're out of there. I don't like to turn the handpiece around. Maybe I'm just not as facile with doing that. I don't like to worry about nicking the iris or the cornea with the tip of the thing, but I'm out of there with that method. But a lot of people like to go in one direction and then back down in the other, whatever you're more comfortable with. And then you can put a suture through your incision. It's often not necessary because it's so small, but if you're doing it in concert with cataract surgery, certainly you have to put one at the end of that to make sure you get a nice firm globe so that there's minimization of reflex bleeding. A lot of patients, if they rub the eye or whatever, they might burp the wound, which if it's just a straight phaco, it's no big deal. Low pressure and the eye fills back up again in 30 minutes. But if you've done something where you can get reflex bleeding, those episodes of hypotony can increase your hyphema. So I like to put a suture in. Entering the meshwork, I think these slides make it seem a lot more complicated than it needs to be. You just stick the tip of the thing into the TM and back up a little bit, because some people will get tissue bunching up into the tip of the handpiece, and so when you try to push along, it doesn't move very easily. So if you back up a little bit, that'll free up whatever tissue got bunched up in there prior to initiating the ablation. Because when you just enter it, all you're doing is tearing into tissue, and it will bunch up into the tip of your device until you actually start ablation, where you shouldn't be getting any kind of resistance. If you're maintaining your tip in the iris plane, but in Schlemms Canal, with the tip of the handpiece not aimed up toward the cornea or in the iris, but just iris plane, you should not feel any resistance. If you are getting any resistance, it means that you need to back up a little bit and reestablish the angle with where you're going. So it's a really nice kind of foolproof method. You can't push this thing into the sclera. It won't physically let you do that, so it's quite nice. Removing the meshwork, again, is just as simple as pushing down on the foot pedal to, once you get that high-pitched ee sound, you know you're there, and you'll see bubbles being formed at the tip of the handpiece, and that's the ablation. Sometimes if you're stopping for whatever reason and you keep your foot depressed, you will see some charring there. Not a big deal, but that does indicate that you need to lift off the foot pedal, back your handpiece up, and start again.
Can you say sound again?
Ee.
Okay.
Did you get that? Okay. And then reflux blood in Schlemms Canal. You're used to seeing it since you operate in the angle all the time, but it's not a complication, it's an expectation. This is Dr. Maeda inducing hypotony so that he can get reflux bleeding, because that really does help to identify Schlemms Canal. That nice red stripe is kind of unmistakable. You know where you are. So you don't, when you're dealing with patients who have a non-pigmented trabecular meshwork or a very shallow chamber with a kind of closed angle, it's difficult to identify sometimes. So this is what the angle looked like prior to him inducing hypotony. You see this patient has a fairly non-pigmented TM. You're just seeing it because of the different shading there. So it can be a little bit tricky in a new adopter of the technology, but once he started inducing hypotony, the canal was very easy to identify. This is a video of Dr. Don Minkler performing the ablation as a standalone procedure, not in combination with cataract surgery. You see that white stripe there at the trailing end behind the handpiece? That's the back wall of Schlemms Canal. It's really quite nice when you see it. It's very bright, so it's different from scleral spur or Schwalbe's line. It's a different whiteness, you see. It's got a sheen to it. It's kind of cool. And then he took it for as far as he could there. So that's a nice, at least 90 degrees. And he's just continuing and then coming on out. And he's hydrating the wound there and placing a suture. This is Gary Condon's video of trabectome combined with phaco. And I believe he's going to do the trabectome first, if I'm not mistaken. Yeah. So this is a patient with a very densely pigmented TM, a deep chamber. Not every patient is going to have this beautiful architecture and landmarks there. So I really like the hypotony-inducing step. And you see the bubbles forming. He's moving along. He's not getting caught up on anything. So he's maintaining the orientation of his handpiece perfectly in the iris plane. And so that was a really perfect ablation. I think he's going to turn his handpiece around and go in the other direction there. And there he's going back through just to make sure he got anything that was remaining there. I think a lot of us like to go back through even when there's nothing to get.
With the cautery on, with electrocautery on?
Usually off and then on again. I just think it's a lot of fun. There's no reason for me to be doing it. Once you've got the ablation, it's kind of done. But I have fellows in the room and I like to say, oh, look at this, like he's doing here. He's just going kind of back through and then, and then he'll kind of touch the foot pedal and reactivate the electrocautery just to make sure he got any remaining strands or whatever. And there's some back bleeding from a collector channel there, very nice to see. And then he's enlarging his incision to do the phaco. And so he did the trabectome with a dilated pupil, which is certainly, you can do it, especially with the IA that comes with the handpiece. It maintains a nice chamber, and you certainly can do it with a dilated pupil. I think most people do. But I like to do the cataract first and then put in Myocol. That constricts the pupil and then do the phaco. And this is Dr. Maeda showing you the setup. He rotated the patient's head. And he's making his incision here. He likes to flare his incision internally. He's rotating the patient's head away from him and the microscope. He's getting quite the tilt going on that thing. That's a lot of tilt, but it works for him. Again, this is another patient with pretty good angle landmarks. So he's right-handed as well. He's placing the gonio lens on with the left hand. I think the most important step for early users is to, when you're first trying to get a view, it's easy to press down on that gonio lens because you're trying so hard to see, and so it's easy to press down on it to see if it will improve your view, and that just makes more stria in the cornea, makes it worse. And so I find that a lot of times with fellows that are doing it, the most important thing is to just keep reminding them to lift off on the gonio lens, don't push down. And as soon as they do that, the view is immediately more clear. And he's just continuing his arc of ablation. So he rotated his handpiece to go in the other direction. And in this case, you saw that to do that, he removed the gonio lens and he kind of stabilized his right hand with his left hand. A lot of surgeons don't need to do that. They leave the gonio lens on. I do. I like to stabilize one hand with the other, and therefore I just forego this whole step and just do it in one pass.
Yeah, because I don't like putting eye stencils backwards either.
Yeah, I don't know if that's a commentary on my facility with the hand, but I don't know.
It's
Whatever.
So much better already.
Yeah.
Backwards.
Exactly. And I think we get set in our ways after a few years in surgery. I feel like, 10 years ago, I would do things a lot of different ways, and now I kind of like find one way that works for me and I just keep going at it. So we get set in our ways, I think. And now he is enlarging his wound and doing the phaco. And he's got his lens in there and he's doing his IA. So everything was done through a dilated pupil there. Post-op care, very similar to what you would do for your standard cataract, which is a topical antibiotic of your choice, usually a fluoroquinolone for 1 week, QID. A topical steroid, a lot of people use prednisolone acetate. In patients who have glaucoma and need a trabectome procedure at the same time, I do find that you will see IOP spikes with steroid use that is a more potent steroid, such as prednisolone or Durezol. I do feel that there is some effect of these high potency steroids on the collector channels. So not just the TM is involved in a steroid-induced IOP elevation. And so for these patients, I like to use a lower potency steroid like an FML or a Lotamax or something like that. Pilocarpine to keep the iris on stretch, usually QID for a month. Some surgeons like to continue it for up to 2 months and feel that they get better response. Obviously, this is at your discretion. Certain patients are at higher risk for postoperative inflammation, CME, or retinal detachment. In those patients, you can just leave off the pilocarpine. But in others, I do find that it does make a difference. If you can use it, you will get a better long-term result.
Do you use it for the full 3 months?
I use it for 2. And then when do you resume glaucoma meds? A lot of times, post-op day 1, you'll have a very profound IOP lowering, and so a lot of people are tempted to leave off meds and then just add them back one at a time if or as needed, if and when needed. I find that it's best to resume glaucoma medications immediately after and then take them off as you can, because the patients are a lot happier when they feel that they're first of all, getting rid of medicine and they're happy. But if you tell them, oh, we're going to have to add one more drop, or oh, we may have to add the other drop, then they feel like there's some level of failure there. I kind of like to set them up for success, and most of the time you are able to decrease medication reliance, and so patients feel a lot happier that way. I always hold prostaglandin after cataract surgery. If you're doing trabectome alone, you can go ahead and resume it immediately, but I find the incidence of post-op CME is a lot higher in patients on prostaglandin, so I don't resume prostaglandin, but the other ones I will. What is the evidence to support using the trabectome? There have been a lot of papers that have been published for over a decade on this technology. There are a lot of newer angle-based procedures that are coming to market and have over the past couple years and will over the next few years. Unfortunately, the data to support the efficacy of these procedures is severely lacking. The safety, I think, is there for all of them. But the efficacy is quite questionable. This is not the case with trabectome, which is part of the reason why I use it, but also because in my experience, it reflects what is in the peer-reviewed literature, which shows that it is highly effective and maintains its efficacy for the long term. I have patients who've undergone this procedure 10 years ago and continue to do quite well. Whereas unfortunately, if you are interested in using evidence-based medicine to guide your method of practicing medicine, the evidence does not support using some of these other technologies. One paper that I was involved in publishing the first decade of global trabectome outcomes, where we looked at some of the early cases of many of the surgeons worldwide. So the first 20 cases of the trabectome surgeons, the patients' results are submitted back to the company for long-term maintenance of making sure that the patients are doing well, that the surgeons get whatever updated training if they need to troubleshoot anything. The company kind of keeps tabs on the first 20 cases, and so that forms the basis for a database where we can look at some of these outcomes long-term. Unfortunately, this includes all of the surgeons' learning curve. And so I think this often will reflect a worse outcome than what the surgeon will expect to achieve once they become more facile with the technology and doing angle-based surgery. And despite that, the outcomes are still quite good, quite remarkably good. And so we have kind of international data to look at. And we looked at 4,659 trabectome surgeries, with some cases being followed up to 90 months. So that's a long-term follow-up with a huge number of patients. And what we found was that you can expect to reach mid-teens pressure with fewer medications post-op than you did pre-op. Now, this is the thing. If you expect to perform this procedure in a patient with a pressure of 15 that you would like to get a pressure of 10 out of, it's probably not a good choice, because what we find is that the expected IOP will be in the mid-teens regardless of where the patient started at. So if you start, in fact, I just did a case this week in a patient whose pressure was 65, and I got a pressure of 8 post-op day 1. But by post-op day 3, she's stabilized at around 15. And that will be true if you start out at 22, 21, 35, 65. So it's not for low-tension glaucoma. This is certainly for someone in whom you'd be happy with a target pressure in the mid-teens. The criteria for survival is pressure lower than 21 millimeters of mercury and IOP reduction of at least 20% from baseline, so it's both, and no additional glaucoma surgery. And what we found is that in patients who had trabectome phaco, the success rate was about 85%, which is quite good. Trabectome alone, 56% at 90 months, which is higher than what you would expect with a trabeculectomy with mitomycin C. We have long-term data on trabs and tubes, and certainly those also have a finite lifespan. And so this compares quite favorably with those. And overall, when both procedures are combined, we have an overall success rate of about 66% long-term. It's a very busy slide with some patient demographics. The important thing to note here is that This included patients with all types of glaucoma, including some angle closure, steroid-induced uveitic glaucoma, juvenile, and also all races were included as well. So when you look at the published data on a lot of other procedures, they're really subgroups of patients, but this really includes all comers. Some of the post-operative observations here as compared to some other commonly performed glaucoma surgeries like trabeculectomy or tubes. You don't get any wound leaks. This is not, does not require a bleb for function and long-term outcome. No cases of aqueous misdirection have been reported. No endophthalmitis, blebitis, those types of things. Another article that Dr. Francis published back in 2010 with trabectome combined with phaco versus phaco alone. And this is just his personal data and does not include the trabectome database. He had 114 patients in the trabectome and cataract group with 145 patients in the cataract alone group. Since there's always speculation on is it the cataract alone which is causing the IOP reduction and not perhaps the angle-based glaucoma procedure, so he was attempting to answer that question with this review. The post-op IOP in the trabectome and cataract group was in the mid-teens at about 15. And in the cataract alone group, it started to go back up once he got an initial IOP reduction and was lower than it started out at. Both groups had a IOP above 30 pre-op. At 1 year post-op, the trabectome cataract group had a maintenance of their IOP reduction into the mid-teens, whereas the cataract alone group continued to creep up and was above 20 millimeters of mercury. So there is an additional IOP lowering effect seen with the trabectome here, that it's maintained long-term. And this was his survival curve. The cataract alone group only had a 45% survival at 25 months, whereas the cataract and trabectome had an 80% survival. And that used the same stringent success definition as the previous study, with IOP lower than 20 with an additional 20% reduction and no secondary surgery. This is another paper we published in 2010 looking at 3 surgeons' outcomes. Again, not the trabectome database. We had 538 patients in the trabectome group and 290 in the trabectome cataract group. And again, we found very similar results with trabectome alone having higher pressure than the trabectome cataract group, followed out for 1 year. The medication reliance was also less in the trabectome cataract group and in the trabectome group alone. Trabectome alone had a 64.9% success at 1 year, and the trabectome cataract 86.9%. So there certainly is a better response when performed in combination with cataract. But when you look at cataract alone compared to trabectome phaco, the trabectome phaco group has a much better result than just phaco alone. So there seems to be some sort of synergy, whether it's because the angle is deepened, whether it's because that cleft remains on better stretch when there isn't a lens there pushing the iris up, or some other angle congestion theory. Whatever it is, it seems that performing trabectome in combination with cataract surgery gives you better results. What about specific subgroups? Pseudoexfoliation was looked at as compared to just primary open-angle glaucoma in a paper that was written by Dr. Damji, Stiles, and Ting back in 2012 in the Journal of Cataract and Refractive Surgery. They had 450 patients in the primary open-angle group and 67 patients in the pseudoexfoliation group. And they looked at trabectome alone in that subgroup, and then trabectome phaco. They had 260 subjects in trabectome phaco group and 45 in the pseudoexfoliation group. And these are the outcomes here. It looks like the trabectome phaco group had a post-op IOP at 15, maintained out to 12 months, whereas the trabectome alone group had a slightly higher IOP, somewhere around 17 or so. But the pre-op IOP in the trabectome alone group was much higher than the trabectome phaco. And basically what explains that is a lot of times when you're going in to do a cataract for someone who has a visually significant cataract and they're already on glaucoma medications, you may choose to pair that with a trabectome procedure. And so these people don't necessarily have uncontrolled pressure, but they have a visually significant cataract. Whereas in patients who had trabectome alone, you're going into surgery because they have uncontrolled pressure. They have a much more profound IOP reduction, but like we mentioned earlier, it doesn't matter where you start at the pre-op IOP, you end up kind of in the mid-teens. And the pseudo-exfoliation group enjoyed a nice IOP reduction as well, down to about 15 millimeters of mercury. In summary, for this study, IOP was lowered to the mid-teens in both groups, and overall they had a bigger IOP reduction in the pseudo-exfoliation group. And then secondary open-angle glaucoma, this was published in 2013, looking to compare the efficacy of different glaucoma subgroups. Wow, this is a very busy slide, and I really don't think I can see all of that anyway. I'm passing through that, guys. Trabectome after failed trabeculectomy. So that's an interesting subgroup because these are patients who tend to have a high scarring tendency and higher rates of inflammation. So the question is, can I try a tube? Should I try an angle-based procedure? Dr. Lowen and his group published this in 2013. They looked at trabectome outcomes after a failed trabeculectomy. Very similar survival rates at 1 year, 81% versus 87% in the trabectome phaco group versus, it seems like, just the trabectome group after failed trabeculectomy. This is quite high survival rates in people who have a tendency for scarring. So it certainly is an option. There's also a study that compares, or that looks at trabectome outcomes, or trabeculectomy outcomes after a failed trabectome, and compared primary trabeculectomy versus trabeculectomy after failed trabectome. And Dr. Rhee and I published that together, and we found that it doesn't affect the outcome of your trabeculectomy. So trabectome doesn't affect the outcome of your trabeculectomy, and a prior failed trabeculectomy does not affect the outcome of your trabectome. So it's nice to let patients know that if they have a prior failed tube or trab, they can always have a trabectome, or if their trabectome doesn't work for them, it doesn't preclude them from going on to have other higher risk, more invasive surgeries.
Do you do trabectome commonly after tubes?
All the time.
Oh, yeah?
In fact, this patient with a pressure of 65 that I just told you about from Wednesday, she had a prior failed tube and trap.
Oh, wow. Okay. That's good to know.
Yeah.
I've been doing tubes and diodes, like additional tubes and the diodes.
Yeah.
afterwards, but-
Try it.
Okay.
You'll like it. So where does it fit in the spectrum? You can do it in early glaucoma, prior to any incisional surgery, or like we mentioned, it's quite effective in patients who have had failed incisional surgery and have intractable glaucoma. So it can fit anywhere in the spectrum, really.